On behalf of the Academy of Osseointegration and the Dental Guys podcast, I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
Well, John, we're back again with another great interview to kind of finish out the day today. I mean, we have seen and heard so many things that help raise our dentistry to the next level. And I think thinking about what's possible today with digital dentistry, right? It's kind of been like a thing that we've talked about with Christian Coachman and this idea of the digital cloud per se and your digital treatment planning methods and all that.
The virtual patient.
But like this workflow, the process, right? John, introduce our guest and let's go.
Yeah, well, welcome to the show, Dr. Eva Anadioti, and she comes to us from Penn, right? And welcome to the show.
Thank you so much for having me. I'm really excited about our discussion and to meet you.
Yeah. We're happy to get to have you. And we were kind of connected a little bit to you as well. We mentioned before the show by Mark Ludlow, who's a longtime friend of mine and was training around the same time as you at UNC. And we talked about at the beginning of the show, you kind of hit that training at an interesting time. You know, you had some really great names there that you were learning from, and digital, I know, was a huge part of that training, both from an implant standpoint and the prosthodontics standpoint. Talk a little bit about what you're doing now at Penn with digital workflow. And I mean, that's a very broad topic, right? So maybe we can talk about, single units and then maybe a little bit about full arch as well. What are some of those aspects that you're most excited about with digital workflow and what you're teaching?
Sure. I'm going to start a little bit with my journey so you understand where I'm coming from. I did my prosthodontic training at the University of Iowa. And at the same time as my certificate, I was doing my master's degree, which was all on CAD/CAM. And that was about 7-8 years ago now. So I was involved with digital dentistry really early on when the indications were very minimal, and especially prosthodontists were not really embracing that technology back then up to our standards. And then I was very fortunate immediately after my pros training to go to UNC and do an implant fellowship. That's where I met Mark, and I worked under great mentors. And that kind of completed my digital training and tied it with implant dentistry at the same time. So ever since, I have been in academics. I was teaching at Boston University for a year, and then I moved as a full-time faculty at the University of Pennsylvania. I've been there 7 years now, and I'm the founding director of the prosthodontics program. So I had the opportunity to combine my training and develop a brand new curriculum.
Wow.
There was nothing there before. So it was like a blank canvas. I had freedom to create it as ideal as possible.
That's exciting.
Yeah. So you're starting with digital.
Exactly.
Right.
So I had the chance from day one to create a combined curriculum where the residents are going to do all of the steps to fabricate fixed prostheses, whether on teeth or on implants, with a conventional workflow, and the exact same step with the digital workflow from day one 5 years ago with the first residents. So they would prepare the teeth. We use microscopes. All the preparations are done under a high magnification. And then they would make their conventional impression, and then they will do an intraoral scan. They will pour the impressions, and then they will take jaw tracing to mount the cast digitally as well. Then they will fabricate, conventional crowns. Then at the same time, they will mill crowns. And we would use intraoral scanning and chairside milling, but they would also do the workflow where they would digitize the conventional casts with the dental laboratory scanner and then mill from a 5-axis milling machine. So absolutely any possible workflow for fabricating conventional and digital fixed prostheses is part of our curriculum from day one.
So with all this new sexy digital technology, why do we need all this conventional workflow stuff? Why is that still so important?
Oh, I know. That sounds exactly like all my interviews when I
Do
interview
we still really need Infragum? I mean, why?
That's right. Yeah. And actually, all the residents, the applicants that we have, over 100 every year, they do want to come to our program because they hear about our workflow that has been established from the beginning and virtual treatment planning and everything else. And they're very excited to jump on it. And I allow them. So when I teach you in the first 2 months, both workflows, conventional and digital, then you're allowed to choose whichever you want with your patient afterwards. So obviously they all choose the digital one. They scan everything and then they go ahead and try to do full mouth cases. Only a few months later to find out that they're just super frustrated. They cannot manage the basic steps. Every result comes up either canted or doesn't fit very well, or something does not merge with something else, or the superimposition is wrong. And then they always are like, okay, next case, I'm just going to do it conventional. This is taking way too much time. I don't understand. And when they go back to conventional and just do a case or two and understand the analog workflow and understand how each step is meant to happen, then all of a sudden digital becomes so much easier afterwards. And now the third-year resident, I can't keep up with them.
Okay.
So it is super important to still understand analog, conventional workflow before you jump into the digital. I can see it every day with my residents, and those are, highly qualified people that graduate from dental school, so they have a pretty good understanding of dentistry already, but they don't have the experience of doing complex treatments.
Well, Instagram has not helped that, right? Because we see the before and after. Oh, this was done fully digital, it says, but the steps in that are not easy always. And talk about that when you get through. So how long does it take a resident, do you think, after doing both these workflows and kind of being maybe humbled a little bit back to the conventional way before you feel like because I'm thinking about dental students, for instance, and what coming out of school, I mean, there's a lot of companies represented here that will gladly sell you all of the equipment and the computer and the printer. How long does it take a resident, do you think, before they are competent and ready to start to implement the digital workflow in their practice?
Yeah, that's a good question. And unfortunately, the answer is it depends. Just like everything else, it depends on the level of skill set and knowledge of that person and their interest on learning. Because there's going to be a lot of stuff you have to try by yourself, and you learn through a lot of trials and errors. So for dental students, we do teach digital workflow, but there we keep it a little simpler. Single tooth, where you have a stable occlusion. There is absolutely no reason nowadays to take a conventional impression for a single crown when you have stable occlusion, especially posterior one.
Yes.
It can be done in one appointment, 2 appointments, whatever, if you want to teach the student how to make a provisional. But it's completely doable, very reliable, very good results. But now a resident that is going to do a full mouth at increased vertical dimension with no reference of where the incisal edge should be, you can do all of that by scanning the patient or make a conventional impression and then digitize those casts. You can take a face scan and then superimpose the intraoral scan with the face scan, because then you can assess aesthetics, right? And you think, that's it. Now I got it all right. So they try that, and we have added now a conventional step right after that. So we 3D print that prototype that you just designed and you're so proud of. And we find more often than not that the plane is crooked, patient does not approve aesthetics, things that are a little bit off. And that's normal because there's some conventional steps that are not 100% reliable done digitally, Facebook, for example. And that's where everybody's focusing right now. So there is no doubt that it will improve, and very soon after. I don't doubt at all about that. But right now, even though we're putting our best effort, the result is not quite there. So yes, go ahead and do digital, whatever you have available to you, whatever you feel comfortable with, but always add a conventional step. Just double check, 3D print something. It's so easy to 3D print at this point, so inexpensive, time efficient. Test it. And then you can add, you can remove, and then rescan this, and then move on to the next step.
The idea of additive manufacturing versus subtractive manufacturing, CAD, CAM, milling, and all those CNC milling, is where it all started. You're very interested in 3D printing, and you just did a presentation here at the AO on 3D printing and really what's possible today, right? And it's amazing how far we've come. Speak to that and where we came from and what are we doing today?
Yeah, possibilities of 3D printing, I don't even think we have scratched the surface at this point. It did start a little bit on the rough side, obviously, just like everything else, but it's improving so much every day. And what is important to understand with 3D printing is that there's so many technologies. Everybody just said 3D printing, they just think it's one thing. But additive manufacturing is 7 major categories, and within those, there are subcategories of those technologies. And whichever one you choose to use, with whichever material you choose to combine it with, whichever brand of printer you choose, you're going to get a different result at this point. And I think that's the important thing that we have noticed. And most dentists now, they don't know what printer their lab has. So they just print something. So we have very little control and understanding of the final product. And I think that's a little bit worrisome at this point.
Yeah.
I also think that they will improve much more in the near future, so you wouldn't have those insecurities. But at this point, having the right selection will make a big difference whether your guide is going to sit or not.
Yeah. And printed models, of course, as we know, we have layers, right? With all this printing technology, there are layers. And the question of, accuracy is one that's, I think, you can address this, but I think largely we sort of know where we are with that. Resolution has been another thing that's been talked a lot about, and how thin can these layers be? And one of the things we were talking about before the show that we maybe, how much can we push this into the anterior world, right? We know that when we have anterior cases, we're trying to go fully digital. When we think about a challenging veneer or a challenging crown, it's not only about shade, it's not only about resolution and accuracy in terms of, how well does it fit, but it's about texture. And, how close are we to a time, at least if you can maybe forecast, where we'll have the resolution to be able to eliminate
wax
the
ups.
stone model from our world? Do you think that's coming? Are we there yet?
We're definitely not there yet.
Okay.
Yes, I would not even consider it for not only an anterior case, but a permanent case at this point. So we've published a review on applications of 3D printing in restorative dentistry. And now we just did another study on 3D printed polymers to compare them with different results. There are several applications, so you can use it for models, you can use surgical guides, you can do it for interim, temporary prosthesis, fixed, you can even do it for anteriors. But we really have very limited data to do it for permanent, whether it's fixed or removable. And I know we're also excited to just jump and start using it for permanent, but the aesthetics are not even close. Unfortunately, both for fixed or removable at this point. Will there get there? Yes. As soon as we start having multi-layer materials that you can control not only translucency, but polychromatic blocks of whatever it is that we're using, yes, we're going to get there. But at this point, I think there's a lot of people that doubt that milling is not good enough for anterior cases, right? We have that discussion all the time that you still need to custom characterization at the end or do some adjustment. It always needs that human touch for the anterior case. And as a prosthodontist, I am one of those people, maybe because of the kind of referrals I get, the patient expectations. So I do appreciate, respect, and definitely leverage digital dentistry in every aspect, subtractive or additive manufacturing. But I think I'm going to put my patient's aesthetics above everything else when it comes to those anterior cases. Suggest milling in whenever it's indicated, but then have my technician finish it.
Let me ask you this. Obviously many of your colleagues that you're training are moving into private practice. Is printing ready for the private practitioner? Can we afford to buy some of these machines and put them into place into private practice? Some of these machines you can't even own. You have to actually lease or rent and pay fees to have them even sitting on a floor. And some of them have to have special requirements for the floor. Is this ready for when these clinicians that you're training from the digital ground up and understanding both worlds? Can they immediately employ these things and actually do it in-house? Because prosthodontists, have been ones that wanted to control things and have in-house labs and those type of things. Or is it reserved for a larger lab?
That's a good question. I think it depends on what application you want to use it for. I think there is room for your diagnostic models or night guards or splints of any sort and temporary crowns. Yes, I can see there the implementation immediately. We are at this point. It's very easy, whichever software you want to use, to just design one of those and then print it. I would not propose it at this point for anything permanent until we have more data, evidence-based that longevity is good, and then, of course, aesthetics. Take, for example, removable dentures. Those are 3D printed. Finally, I'm happy that there is an update in the removable prosthodontics field since it hasn't happened anything for
not a lot
of
century.
Exactly.
A century,
So I'm the first one that I want to go that direction. But we started using 3D printed dentures for temporaries just to test them out. And we already see that within less than a year, aesthetically, they don't look good anymore. From the beginning, we thought that the printed one is not going to look good. But you know how we control that? We only print the base, and then we use prefabricated teeth that look like exactly the teeth that we've been using forever. So aesthetics look good. But then within a year, everything starts turning yellow, it loses its shine, and then we start seeing fractures now too. So I really advocate on evidence-based. Let's just get some studies out there that will fuel the industry to start making those improvements that we need before we go to the final.
Yeah, it's difficult. I think we've seen this huge change over, say, 30 years of used to be that we would see the researchers research a product and eventually that would get it out to the clinician. Now the companies are coming out with new products. Clinicians are sort of being the testers, and then eventually that's being researched. And it seems like that that's not going to change because technology is moving so quickly. I'm sure it's difficult teaching residents or especially dental students on how to make decisions for these things, knowing that it's changing so much. And it sounds like your approach is kind of the wait and see approach rather than just to dive in and buy a bunch of stuff that you're not sure is going to be good in a year or two.
Yeah, I couldn't agree more with you. That's the important thing, is how to teach them critical thinking to make those decisions when the time comes. So that's where I put a lot of effort, trying to explain to them what to look for. So when a rep comes to your office and he has the next best thing, what are the right questions to ask for? And if they provide that literature, what are you looking at? There is certain criteria that they need to meet for you to jump on that boat and just go use it for your patients. Here in an academic institution, we are a little bit more protected. You know, we have the opportunity to test a lot of things more. And that's why I feel the freedom to let them, okay, yeah, just try it. And let's see how it works out for you. If it doesn't work out, they have to redo the step. And patients are kind of prepared that this can happen in an academic institution. But who can afford that in a practice?
Sure. That's right. Who's going to pay for the replacement?
Exactly.
And I remember that being early on, even we talk about, UNC and Lyndon Cooper. We remember years ago being here when he was first presenting zirconia hybrids. This is so many years ago. And he was on the corporate forum podium, and he was presenting these case after case after case. And as it is with the AO, people are opinionated, and I love that. It's one of the reasons we love coming here. And someone literally stood up in the audience and said, "How many failures have you had? I mean, and who's paying for these replacements? And this is not time to get this in private practice. It's not ready yet." And of course, Lyndon replied to that in a very humble way and said, "Yeah, this is an academic institution. We can afford to replace these things if they fail, but in private practice, it's a different world." But I don't know if that's always a message that's getting out.
Right.
I think that the message from, again, social media maybe is more driving.
Well, the shiny thing is what we like to go after.
We do like shiny things.
And I think that that's a distraction sometimes to the tinkers, right? And so I appreciate the evidence-based approach of the academy and what you're doing there at University of Pennsylvania. So let me ask you a question, though, as we're kind of finishing up here in the last 5 minutes. I'd like to talk about maybe some things you can't live without now. I mean, you started this, right? And your passion for digital dentistry started years ago. And what are some things right now that you said, don't take that away from me? I can't live without that in the digital world.
It would be an intraoral scanner.
Okay.
Yeah, that's the beginning of everything, especially now with the newer generation one, that they're much faster, so much more accurate. Even within the same company, the next model, it's day to night at this point, how much more efficient. So from there, that's what I would recommend a clinician that wants to start into digital dentistry to start with. Just get a scanner that you are going to use that has the workflow that matches for you, and get something super complicated with a design software that can do everything if you are not going to be doing everything. Just get something that's simple enough. If you just want to scan and send the diagnostic cast to your lab, just get something simple then. But it's very important to do it. And then once you get familiar with it, then you want to go to the next step. So the next for me would be a software for implant planning. I literally cannot live without it. If I don't have something to open my CBCT and being able to plan the implant placement right there chairside with my patients a lot of time. As soon as the CBCT is out, I'm so curious to see whether I can do it or not, whether we're going to need bone grafts, what angulations. And once you know the software, it doesn't take much time.
No.
But there will be a learning curve, just like with all of us. The first time I used an intraoral scanner, I felt like dizzy. It was that complicated. And I had the chance in an academic institution. I did my research on intraoral scanners. So I did a lot of repetition early on. So that certainly helped a lot.
Yes.
But those two would be my...
So what are you taking impressions of these days, conventional impressions? If we know the intraoral scanner has arrived, but what is the role of traditional impressions in maybe your own world, right? Because everybody has an opinion on this, but we'd love to know how far you push that with the intraoral scanner.
We know how
versus
far
conventional.
Mark's pushing it.
Yeah, right.
How far are you pushing it?
Right.
Yeah, I probably push less than Mark. Knowing Mark, he's going all the way.
Yes, for sure.
I know him. No, I'm much more conservative. So as I said, single crowns, never a conventional impression unless I don't have the scanner. That would be the only reason.
Right.
Some resident took it and I don't have it. Exactly. But I wouldn't do full arch yet. Yeah.
Gotcha.
Is it possible? Sure, it is. Yes.
Mm-hmm.
So what I do is not that I'm not using the scanner. I divide it. So I'm probably going to leave the temporaries on the anterior teeth and just scan the posterior teeth first, as if it's a sectional impression. So something holds the vertical at all times. I don't have to pack cords everywhere, and I don't have to scan everywhere. So it is possible. I have done it, but I still feel that either by segmenting it, or if I must make a full arch, I will do it conventional and then digitize it in a digital lab, that I can have a little bit more control over the process.
Yeah. But what about in the implant world? How much are you doing or teaching as far as full arch digital workflow for implants?
Yeah. So single implant, same thing, full digital, but full arch, not yet. We haven't even tried it yet. So what we're going to do now, we're making our conventional impression. And then after that, we're implementing digital by, for example, the verification jig that we need to do before we move on to your full arch zirconia. Now we 3D print the bars. And we attach them directly to the impression copings or the custom abutments. And then the splinting, the verification jig happens so easily without spending all night for the resident to make the verification jig the night before.
Right.
So we are implementing the technology on later steps, or we 3D print custom impression copings, where we adjust it exactly how it's the printed temporary that we just used.
Are you working on any research right now that you're excited about?
Yeah, it's on 3D printing.
Yeah.
Same thing. Yes. The research that we did, we compared SLA printers, both dental ones and industrial ones, thinking that the industrials will be more accurate, and then compare FDM printer as well. And we found that same technology, same printer, different materials, completely different results. Yes. So it was very eye-opening to us when all of the other parameters are standardized, right? To see how much effect the selection that you're making on the printer technology, actual printer, and the material has on your final product.
Amazing. Is that published now? Or
it's accepted, yeah. So it will be published in the Journal of Prosthodontics very soon.
Yeah, that's a big deal. And I think we've all been sort of waiting for that type of data. Because there's, again, so much innovation, new products, new scanners, and we're all kind of waiting to see, well, how much does it matter? How much money do you need to spend? And which materials, does the material matter more or the scanner matter more?
Exactly.
And it sounds like that's exactly what you're answering with this.
Yeah, those were our questions, and we're trying to standardize a study design so we can keep doing it with whichever other technology comes out.
Now that's huge. That's what we need. That's what we need, I think, is a way to actually standardize. And that's something we've been talking about on the show for a couple of years now. Is, it's very easy to see, we can go to the booth and we can hear the speech, but does it work? And what is a way to actually have a comparison between these materials? Much like we, the ADA developed standards for impression material performance and stone and expansion and contraction. We know these things because we have ISO standards, for instance, and the printing world, it sounds like we're finally maybe getting close to that.
Exactly. Yes. And they are developing those standards too, slowly. And we are using those standards, same designs that we used to mill or make impressions of and then forecast. We're using the same design for the printing now. So we can have pretty much direct comparisons and use the same guidelines that ADA wants.
I like to hear it. And it's funny because it's been around for a long time. We've been wanting this, and really we're just really starting to turn it up, and that's exciting. And the industry is definitely moving in the right direction. I think that we can't live without digital now, and I appreciate you teaching students the analog way as well, because we do have to know how that works, because it is a physical body we're working on. It's not just design, So thank you so much for coming on the show and talking a little bit about what you're passionate about. And
it's been a lot of fun. It's been a lot of fun. And we're glad to see that, things are happening there. We're excited for what you're going to be doing at Penn. and to read that article when that's published.
Mm-hmm.
So we'll definitely be looking out for that.
Thank
so,
you.
Yeah,
it's been a true pleasure.
Yeah,
well,
thank you so much.
Very good.
So
Wes,
John,
man, another good one. And I think this has been a theme. It's been, what can we do with digital? How much can we create a virtual patient?
Right.
What's possible? And I think maybe we've asked that question a couple of times years past, and it's been sort of a stagnant
were
time.
we a little bit hesitant, probably even 3 or 4 years ago, to jump in? Now, both of us have been scanning for a long time.
Yeah.
I started scanning in 2009.
Yep.
Kind of like pushing it cowboyish, as you would say.
As usual.
Pushing it.
Yeah.
But we've been hesitant to move forward, right? Because there isn't the evidence base to certain things. And whenever you have people like Mark, Eva, and really Christian coaching, really working on how to create this virtual patient, do it at a high level, but also have the backing, let the universities lead.
Right. The data on the printers and the scanners, and how does it truly compare to what we have done for years, and teaching both ways of doing something, so you really prove to yourself that what you're doing works, and you can compare it back to the conventional.
Right.
So, well, I'm excited for what we're going to continue.
What's going on tonight, though?
Oh, tonight, I mean,
Top Gun.
If you're not here at the meeting, this is a real shame for you. I'm going to tell you, we are going to be hanging out on an aircraft carrier. Is that right?
Might as well.
It might as well.
Might as well, right?
USS Midway. AO always
Where's
does it
Miramar
big.
at?
That's
right?
Exactly. Fighter
Goose.
weapons school.
Remember, you're Goose. I'm Maverick.
I know. I'll be Goose, I guess. This one time, I still feel the need for speed. I'm going to say it. I had to get it in. I told you I'd get it in on the podcast at some point. But I'm super excited for tonight. We're going to be making new connections, getting to see some people we haven't seen in years.
Yes.
We're all ready for this in-person meeting, and here we are. So. We're sorry if you can't join us for that. You can maybe see some pictures. We'll at least post some pictures. But we're looking forward to coming back with more great content coming up today and tomorrow as we continue with the AO annual meeting. Again, submit any comments, questions to the hashtag AODentalGuys22, and we would be glad to get your stuff on the show if possible as we're continuing with these interviews. So for Eva, for Wes, I'm John. We are the Dental Guys.